prostate cancer traditionally has been treated with either observation or surgery and radiation treatment. There hasn't really been a middle ground, and studies have shown that obviously patients have a lot of side effects with surgery and radiotherapy, and that perhaps there are some cancers that don't need to be treated as aggressively. So there is a growing field now of management and a thought process that maybe some intermediate cancers that are well visualized on MRI scanning or other imaging such as PSMA PET scan and confirmed on biopsies can be treated with focal therapy. So what we do is when we see this abnormality on an MRI scan or a PSMA scan, we can use our transperineal method, which is between the scrotum and the back passage with a grid, to target these areas and to make sure there's no cancers in the rest of the prostate. If we confirm that there's just a solitary cancer in the prostate, maybe even two cancers next to each other, and we have perfect correlation between the imaging and the biopsy, and the imaging can be MRI or PSMA PET scan, then we could consider treating that area with a specific treatment. There's a variety of ways that can be treated. What I'm doing here at St Vincent's is using NanoKnife treatment, which is electroporation. And what we do with that is we put needles in to where the cancer was, surrounding the cancer basically with an extra margin of 1 centimetre, and then we activate the machine and we get electrical energy between those electrodes, and the cells in between then die. The way this works, which is quite unique, is there's no heat treatment. The electrical energy actually makes small holes in the cancer cells and these cells die. So that's called electroporation, and it's a very promising technique. And certainly I think it is something that could be considered for patients who have an intermediate grade cancer, maybe a Gleason 7 or a grade group 2, we call them now, with just a small area of involvement, and those patients could be treated in that way. It's important to know that those patients need to be followed up, and we would usually do an MRI scan at 6 months and a repeat biopsy at 12 months. The complication profile is very low. There's virtually no incontinence and probably only a 10% chance of erectile dysfunction with about a 15% chance of recurrence. There's now intermediate data up to 5 years, which has been very promising in terms of outcomes. So I think this is a very new and innovative technique and treatment modality, and certainly it should be discussed with patients.